Okay, so we are continuing with our nutrition lecture. And in the last lecture, we covered our nutrition section till vitamin A. So we're not that far off, just a bit of an introduction. And the first vitamin, which is the vitamin A, we covered these parts extensively. Now we are moving towards the vitamin B complex. So naturally, vitamin B1 being the first one, which is also known as thiamine. Yeah. So you have to know these names, these second names that they have. Now, before continuing on, you must understand that vitamins are compounds, just like any other compound in the universe. Vitamin is also a compound, right? So this is what thiamine looks like. This is what thiamine is. This is an organic compound. If you studied your organic chemistry and if you remember it well, this is a carbohydrate with the nitrogen and oxygen and sulfate group. So this is what a thiamine molecule looks like. So this compound, mostly the vitamin B complex, they participate as coenzymes or cofactors. So what they're trying to say is that vitamin B, which is also known as thiamine, it can be in the form of thiamine pyrophosphate. So it can have an additional pyrophosphate molecule linked to it, which can act as a cofactor for several dehydrogenase enzyme reactions. So what this sentence is basically saying is that there are a lot of enzymes that carry out dehydrogenase reactions, such as the branch chain keto acid dehydrogenase, alpha keto glutarate dehydrogenase in the DCA cycle, the pyruvate dehydrogenase, which is in between the glycolysis and the DCA cycle, the transketolase that works in the HMP shirt. So these are the enzymes which give rise to dehydrogenase reactions. Okay. And these enzymes, they need a cofactor, and vitamin B1 acts as a cofactor for these enzymes in the form of thiamine pyrophosphate. So if I show you, this is the thiamine structure. Now I show you the structure of thiamine pyrophosphate. This is the structure of thiamine pyrophosphate. Right? So you can see that I'll just zoom in. This is thiamine, and this is thiamine pyrophosphate. Thiamine, thiamine pyrophosphate. So you can see that only the pyrophosphate group, which is this one, which I'm circling with my cursor, has been added to the thiamine molecule. Now, what is the difference and what this pyrophosphate molecule allows? It's not really a part of our domain, but just know that the basic structure is a vitamin B1, and then you can keep on adding groups to sort of modify its function and make it participate in some reaction. So these are the enzymes that it functions as a cofactor, and these are functioning in different processes. So in the DCA cycle or in the HMP shunt, like that. So this is what you have to remember, that in the form of thiamine pyrophosphate can act as a cofactor for dehydrogenase enzymes. So if I could just mark the important ones, so as for dehydrogenase enzymes, it can act as a cofactor in the form of thiamine pyrophosphate. And keep in mind these enzymes. Okay. You will remember them throughout your preparation as well, but it's better to keep them in mind. Now, the deficiency again is important. Like I told you guys in the first lecture, the deficiency is quite important. So, what happens is that when it is deficient, glucose breakdown is impaired. And when the glucose breakdown is impaired, you are not going to make any ATP. So, ATP depletion is going to occur. And of course, this is going to get worsened by glucose infusions. Now, let's say, for example, somebody has no energy. What you're going to do is you're going to give the person glucose, and the glucose is going to be broken down into the ATP. It's going to provide him energy. But if you are deficient in vitamin B1, what happens is that vitamin B1 is, of course, not going to participate in the TCA cycle. It's not going to participate in the the in the middle pathway between glycolysis and TCA cycle. It's not going to participate in the BCAA metabolism. However, that's not a main part of providing energy to the body. But again, it's a part of providing somewhat of energy to the body. However, the PCA cycle is going to be greatly affected, right? So you're not so these enzymes will not be working, and vitamin B1 is not going to function. So ATP production is going to decrease. So if your TCA is not working, so TCA cycle is not working, then obviously you're going to have decreased ATPs, right? But what happens is that, of course, however amount of glucose you're going to give to the patient, when the enzyme is not working, it's not going to give you ATPs. The ATPs are not going to form. And this would in turn be worsened because the more and more glucose that you give to the patient, the more and more uh, substrate is going to accumulate. So we know that if I go back to my whiteboard, we know that there is substrate which passes through the enzyme and it gives us the product. So if you're going to increase the substrate, we're going to increase the substrate. What happens is that the product is going to, and there is no enzyme, right? So there is no enzyme. So what happens is that the product is going to decrease more and more. So decrease because there is no enzyme to process it. So if this increases, the reaction is going to shift to this side, just basic chemistry. We're going to keep on increasing it, so it decrease. So that's what's going to happen. If you even if you don't understand this part, just understand that it gets worsened by glucose infusion. So you don't give glucose infusion first. You always give thymine, right? So highly aerobic tissues they are affected first because they need more. They need glucose. They need ATPs. This is mostly found in patients with chronic alcohol overuse or malnutrition. So what you do is you give thiamine. You always give thiamine before dextrose. Dextrose is is a form of glucose. You always give thiamine before dextrose to decrease the risk of precipitating Wernicke's encephalopathy. Diagnosis is made by increased RBC transketolase activity following vitamin B1 administration. So what happens is that let me clear this off. So what happens is when you administer vitamin B1, the RBC transketolase activity is going to increase because it is a part of the transketolase enzyme, and you can measure this. So you can measure this, but this is not routinely done. So this thing is not, this process is not routinely done in the clinical scenario because what happens with the clinical scenario is that you profile actively give the patient vitamin B1. That's not, there's no need to check the activity and then define it because this is essentially, this does no harm to the patient. So that's not a big deal. All right. There are some things in this paragraph that you might have not understood. Like there have described one encephalopathy. Again, this disorder can be remembered by this synonym, corona beer. This is basically an acute, reversible, life-threatening neurological condition. So this is a neurological condition which is acute and reversible. How is it reversible? You give the patient vitamin B1. That's how it's reversible. The symptoms are very important. So this disease is quite important. You need to understand it, remember it. Confusion, ophthalmology, nystagmus, ataxia, corona beer, right? Confusion, ophthalmology, nystagmus, ataxia. The Korsakoff syndrome is worsening. Is a worsened version of Wernicke encephalopathy. So when you don't treat Wernicke encephalopathy, it worsens into Wernicke-Korsakoff syndrome. Just Korsakoff syndrome is basically an amnestic disorder in which the patient seems to lose some of its memory and then attempts to fill those gaps by lying or creating scenarios. So that is what is confabulation. Confabulation is basically lying to fill the memory gaps. Because patient feels like they don't remember something and they attempt to make excuses or make stories to cover it up. So this is what confabulation is. Confabulation is a key characteristic of Korsakoff syndrome, and personality changes are also involved. So when you don't treat Wernicke encephalopathy, it can lead to Wernicke-Korsakoff syndrome, in which there is extensive damage to the thalamus, to the mammillary body. This has been asked in the NBMEs, and it's a combined presentation of the Wernicke encephalopathy and Korsakoff syndrome. So both of them they present the Wernicke-Korsakoff syndrome scenario. So you will have Wernicke encephalopathy symptoms, you will have Korsakoff syndrome symptoms, which will give you this. Now, beriberi is also a disorder that can occur. Dry beriberi is basically neuropathic disease. Wet beriberi is basically cardiac disease, in which there is high output cardiac failure. Okay. Now, the best way to remember which is dry and which is wet is basically you, well, sort of imagine that the heart has a lot of blood. Blood is wet. So you can remember wet beriberi by blood, and heart has a lot of blood, right? So blood is wet, and of course dry being the nerves, because nerves don't have blood. So you know you can remember it like that. So uh, if you don't give thiamine and you give glucose, which will do worsen your ATP depletion, it can also increase the risk of Wernicke encephalopathy. So clinically, what happens is that if we have a patient that we think is of chronic alcohol overuse or of malnutrition, we sort of profile actively give that patient thiamine injection before glucose. We give it plus IV fluids, because there is no harm in giving this injection. There is no harm. So we sort of give it. We don't really wait for the transketolis activity or test it out. But again, it's a point, so you can remember it if you want to. Moving on to vitamin B2, which is known as riboflavin. It The function is that, of course, now every vitamin is going to have its own structure like this, right? So the structure is not important for you as far as USMLE is concerned, but I showed you this timing structure just to sort of drive home the concept of them being real life compounds. Because sort of oftentimes what happens is that we don't see something, and like organs and everything, we know that they're there, but vitamins we don't really see in their solid phase. So they're sort of hard to grasp. Now, the function of vitamin B2 is that they are components of flavins. So again, other compounds, they are components of flavins, and they're used as cofactors in redox reactions. So vitamin B1 was used in the dehydrogenase reaction. These are used in the redox reactions. They are used in the succinate dehydrogenase reaction in the TCA cycle. It's not purely dehydrogenase reaction. It is a redox reaction. So it's a dehydrogenase and oxygenation reaction together. So basically, what just you need to understand is that they're part of the FAD and FM and uh, compounds, the riboflavins. Deficiency is cherosis. This is the inflammation of the lips, scaling in the fissures of the corners of the mouth. So you can see this right over here. Okay. and magenta tongue and corneal vasculation. So the tongue gets magenta colored, you can see, and there's corneal vascularization. So chelosis, magenta tongue, and corneal vascularization. So you need to remember the definitions. Chelosis part is quite common in the vitamin B complex compounds, but you need to remember this. Vitamin B3 is also known as niacin or nicotinic acid. It's probably one of the more important vitamin B complex components. It is a constituent of the NAD and NADP compounds, again used in redox reactions and cofactor, and that derives from tryptophan, which is very important. Why it's important, we're going to see in a moment. So the synthesis requires vitamin B2 and B6. So to synthesize vitamin B3, we require B2 and B6. We require riboflavin and we require uh, pyridoxine, right? So it is used to treat dyslipidemias. So it decreases VLDL or it decreases HDL. So they are used, niacin is used to treat dyslipidemia. So these are important points, all of them. The deficiency, very important. Glossitis and severe deficiency of B3 leads to pellagra, which is a basically pellagra contains of a triad you might have studied in your med school as well: diarrhea, dementia, and dermatitis and death. Right. So diarrhea, dementia, dermatitis, and death. It can also be caused by heart nerve disease. Right. So pellagra can be caused due to the inherent deficiency of B3, or it can be caused due to heart nerve disease. So what is heart nerve disease? Is basically autosomal recessive disease. It's a deficiency of tryptophan transporters in the proximal renal tubule, which basically leads to uh, amino aciduria and a decreased absorption from the gut. So it leads to basically tryptophan deficiency. So there is going to be less tryptophan. And this is a problem because we studied over here that this is derived from tryptophan, right? So this is a problem. So when the tryptophan is going to be less in the body, uh, what's going to happen is it's going to lead to deficiency of niacin or vitamin B3, and this is going to give rise to pellagra-like symptoms. So in this disease, what we usually do is we treat it with a high protein diet so that we could have a good supply of tryptophan, and we also give the patient nicotinic acid. So inherently, deficiency of vitamin B3 can lead to pellagra, or heart nerve disease can lead to pellagra. Malignant carcinoid syndrome can also lead to uh, pellagra, and malignant carcinoid syndrome has a sort of a similar mechanism as heart nerve disease. So heart nerve disease is basically inherited tryptophan deficiency. Malignant carcinoid syndrome is acquired tryptophan deficiency. The carcinoid syndrome, what it does is that it produces serotonin. So it is basically a sort of a neoplasm that produces serotonin a lot. And serotonin is derived from tryptophan. So tryptophan also creates serotonin. Not only does it create niacin, it also creates serotonin. So what the neoplasm does is that it forms serotonin excessively and it uses tryptophan in that process, right? So of course, if serotonin is going to be formed excessively, tryptophan is going to decrease and it's going to lead to pellagra again. So it's going to be the whole cycle. So inherent B3 deficiency, heart nerve disease, malignant carcinoid syndrome, and isoniazid, because isoniazid can lead to the deficiency of vitamin B6. I don't know if you guys saw it, but it can lead to a deficiency of vitamin B6. So over here, we studied that we need vitamin B2, B6, and tryptophan for the formation. So tryptophan deficiency, however it occurs in studied heart nerve disease, or malignant carcinoid syndrome, inherently deficient B3. But B6 can also be deficient when the patient is taking isoniazid. So it's very important that you give the patient pyridoxine or vitamin B6. Pyridoxine is just a name for vitamin B6. You give patient pyridoxine with isoniazid. It's very important. So these are the causes of pellagra. These are the symptoms: diarrhea, dementia, also hallucinations, and dermatitis, which is usually in the C3, C4 dermatome and can lead to Castle necklace. So you can see Castle necklace right here. Right. I will show you guys over here. This is the dermatome C3, C4, and this is the Castle necklace. You can see this. Right. Picture is important. It can lead to Castle necklace and hyperpigmentation on the sun exposed limb. So you can see the hands in this picture. This is the hyperpigmentation. Pictures are very important. So you need to keep this in mind. Now, the excess of this vitamin, it causes facial flushing, and it is induced by prostaglandins. It's not induced by histamine. So you can basically take aspirin and it's going to solve your facial flushing. You have to take it before niacin. So niacin, we studied over here, is used to treat dyslipidemia. So people consume niacin. They're prescribed niacin if they have a dyslipidemia and the doctor seems fit. They are prescribed niacin, and the most common side effect is facial flushing. Right, and you can take aspirin to avoid it. Writers and hyperglycemia and hyperuricemia can also occur, but facial flushing is the main one. So vitamin B5, also called pantothenic acid, and B5 is known as pento in mathematics. So they're trying to give you a mnemonic here. Function: it is a component of coenzyme A, and if you remember, you must have seen this CoA part with many enzymes throughout biochemistry. So the main part of CoA is pentothenic acid. It is usually in the acyl transferic reactions and fatty acid synthase. Deficiency deficiency is dermatitis, arthritis, alopecia, adrenal insufficiency. It may lead to burning sensation of the feet, right? So this is important. It might lead to burning feet syndrome, blissful paresthesias. Now, you have to make sure that you don't confuse this with being a clot or anything, because this can be similar to it. Also, you might have a burning sensation of the feet in diabetes, in HIV. It's neuropathic pain. So you have to be careful of that. The patient history is going to be very crucially whenever you're going to solve these nutrition questions. So you need to take care of the history, and you have to make sure that you look at the history properly before going forward. Vitamin B6 is pyridoxine. This is also an important vitamin. It's converted to pyridoxal phosphate, then used as a cofactor in many transamination reactions. ALT and AST, which are your important liver enzymes, they form through a transamination reaction. Decarboxylation reactions, glycogen phosphorylase, synthesis of glutathione, cystathione, and heme, niacin, histamine, serotonin. So it's a very important vitamins involved in all of these processes, and you have to keep in mind all of them. Deficiency can lead to conversions, hyperirritability, peripheral neuropathy, deficiency inducible by isoniazid and oral contraceptives, sideroblastic anemia due to the impaired hemoglobin synthesis. So in sideroblastic anemia, if you have not seen our anemia lectures, you should check them out. In sideroblastic anemia, I've explained that how pyridoxine it's important because this is a cofactor in the first part, the process of hemoglobin synthesis. That is why it can lead to sideroblastic anemia, and it's also very important part of the nerves. So it can lead to peripheral neuropathy, which is induced by isoniazid and oral contraceptives. So you need to remember both of them. Isoniazid is classical, so most people don't tend to forget isoniazid, but they do tend to forget the oral contraceptives. So that's it. Vitamin B7, it's also called biotin. It's a cofactor for carboxylation react enzymes, which add one carbon group, right? So they are basically carbon donators. That's what I would like to call them. They basically donate carbon and cause carboxylation to the compound that is undergoing the change. So they're used in various enzymes, pyruvate carboxylase, acetyl CoA, propenyl CoA carboxylase. You just have to know the enzymes in which this is used, nothing much in detail. You don't have to know all of this, just the enzymes that are being used. Deficiencies here but can cause dermatitis, centritis, alopecia. As I've told you guys, that this is the common theme regarding the B complex vitamins. And it can be caused by long term antibiotic use or excessive ingestion of raw white eggs. So, this is important because I have seen a question a few times of this part, but it can also be due to the long term use of antibiotics. So, keep both of them in mind because there's a compound in the eggs whites which is known as avidin. So, if you consume raw white egg whites, not cooked raw egg whites, then this can lead to deficiency of vitamin B7. Vitamin B9 is also called folate, and it's also one of the more important ones. It's converted to tetrahydrofolic acid, a coenzyme for one carbon reaction. So you don't need to remember this, but this is important. That is converted to THF. And it is important for the synthesis of nitrogenous bases of DNA and RNA. It's quite important. And it's found in leafy green vegetables. So a person who is basically in a very bad diet, imbalanced diet, it can lead to vitamin B9 deficiency. It has a small reserve pool. It's stored more primarily in the liver, as opposed to vitamin B12. They primarily are studied together. Vitamin B12 has a large pool, right? B9 has a small pool, and vitamin B12 has a large pool. So if it is a chronic malnutrition, then you can think about V12. If it's recent malnutrition, you can think about V9. Deficiency can lead to megaloblastic anemia. This you all know. Hypersegmented polymorphonuclear cells, leucitis. There will be no nuclear symptoms as opposed to vitamin B12 deficiency. I hope you all of just know this. All of you know this. And homocysteine is going to increase, but the methylmalonic acid is going to stay the same, whereas this increases in vitamin B12. And this can be seen in chronic alcohol overuse. So, one thing that I would like you guys to remember mostly is chronic alcohol overuse and pregnancy. Both of them can cause B9 deficiency. All of this you would remember anyways due to studying other such symptoms systems. Deficiency can be caused by several drugs, anitoin, trimethoprim, methotrexate, and supplemental folic acid is at least 1 month prior to conception. So this is also important that the females who are expecting to get pregnant, you have to advise supplemental folic acid. If uh, the person, if the female has a report of neural tube defects in the previous pregnancy, then she needs an increased dose. So if she has a child with neural tube defects or risk factors of neural tube defects in last pregnancy, then she needs more B9. Okay. And also remember to keep in mind these drugs as well. Yep. So cobalamin, which is vitamin B12 now, it's a cofactor for methionine synthase and basically transfers CH3 groups as methylcobalamin and methylmalonyl CoA mutase, which is also important for DNA synthesis. So the function is not really important, but we just have to know the efficiency part. It's very important. It's found mostly in animal products. as opposed to B9, which was found in green vegetables only. And it is cytosynthesis in humans is distal to the site of absorption. So B12 must be consumed via animal products as we need it in sufficient quantity. So we must consume it. So a vegan person might have a deficiency, right? Megaloblastic anemia, it can cause hypersegmented PMNs, paresthesia, subacute combined degeneration. It's important. It's the degeneration of the dorsal columns, lateral corticospinal tracts, spinal cerebral tracts. We have normal myelin. So it is a component of the myelin, and when it is deficient, the myelin becomes abnormal, associated with increased serum homocysteine and increased methylmalonic acid levels, along with secondary folate deficits. Because obviously, when it gets stuck, so folate cannot form tetrahydrofolate. So there is a whole process there, as you can see, that if vitamin B12 is not there, the THF is not formed, the THF decreases. So it can cause B9 deficiency as well. So these both of them are connected in some way, in this way. However, prolonged deficiency can lead to irreversible nerve damage. It has a very large reserve pool, several years. So again, the history point is going to come in play over here. It is stored primarily in the liver, deficiency caused by malabsorption. So any disease that causes malabsorption, sprue, enteritis, Daphlobacterium latum is a parasite, and atelorrhea, bacterial overgrowth, alcohol overuse, lack of intrinsic factor, which is primarily the reason in pernicious anemia and gastric bypass surgery, absence of terminal ileum due to surgical resection in Crohn's disease, or certain drugs such as metformin. It's important that you keep this in mind. And veganism is also a reason for the deficiency. Now, if you give B9 supplementation in a patient who is B12 deficient, it can solve the hematologic symptoms, but it will not solve the neurological symptoms. So, what happens is essentially in a clinical scenario, both of them are given together, B9 and B12, prophylactically. All right, even if you're not sure the patient has one deficiency or the other, we tend to give both of them together. Vitamin C, also called ascorbic acid, that was the wrong line, also called ascorbic acid, antioxidant, important, also facilitates iron absorption. Again, another one point by reducing it to the Fe plus 2 state. So, Fe uh, plus 3 state is not absorbed of iron, right? So, you need it in Fe plus 2, are necessary for hydroxylation, proline, and lysine in collagen synthesis. We already know that the deficiency of vitamin C can cause scurvy, as we can see. So, it is important in the collagen synthesis. And it is also necessary for dopamine beta hydroxylase, which converts dopamine to norepinephrine. You have like four functions: antioxidant, reducing iron, collagen synthesis, and necessary for dopamine uh, beta hydroxylase, which converts dopamine to norepinephrine. So you got four functions here. It's found in fruits and vegetables and ascorbic absorbic acid. I don't know what they've written here, but you can see for yourself. Ancillary treatment for methemoglobinemia by reducing Fe3 So this is a miscellaneous point. Is important that it can be used in the treatment for methemoglobinemia. So this is a supportive treatment. This is not a definitive treatment of methemoglobinemia, but it can be used because in methemoglobinemia, the big problem we have is that the iron is oxidized. So vitamin C can reduce it to Fe plus 2. Deficiency can cause scurvy, swollen gums, easy bruising, petechiae, hematorosis, anemia, poor wound healing, perifollicular and subperiosteal hemorrhages, corkscrew hair. If I can show you guys, you can see this is a animated illustration, but you can see that you can get joint pain, immune impairment, digestive disorders, nose bleeds, easy bruising, slow wound healing, gingivitis, dry skin. Is what you can get. uh, show you guys. You can see this hemorrhages, right? And the pulse screw here is also important. Let me show you because I've seen them in your world. So you can see this is how they. You see that they are in this screw shape, right? So they would be in this shape. In this one, they would be like this. Deficiency may be precipitated by tea and toast diet. This is a buzzword. It doesn't really come in exams anymore, but they usually describe an old female living alone and she just consumes tea and toast and biscuits. That's it. So this is a buzzword. Yeah, it's good to keep in mind, but I don't think that it really does come now. Deficiency of vitamin C can lead to a weakened immune response. Vitamin C can cause scurvy, and this is another mnemonic. Excess of vitamin C can cause nausea, vomiting, diarrhea, fatigue, calcium, oxalate, gases. Excess oxalate comes from the vitamin C metabolism, so it can cause kidney stones and can also increase iron toxicity in predisposed individuals by increasing dietary iron absorption. So it can, people that already have hemochromatosis and a lot of iron in their body, vitamin C can worsen it due to increased iron absorption. And this could be like two kind of patients: a hemochromatosis patient or a patient that has transfusion related iron overload. So you need to be careful in those patients. Vitamin D. D has multiple forms. And D3 is cholecalciferol, and it forms from the exposure of the skin to the sun. So this one is the classical D3 that we get from the sun or the diet and ingestion of fish, milk, plants. D2 is ergocalciferol, and it comes from the ingestion of plants, mostly. They both are converted to 25 hydroxylase D3, which is the storage form. And then there is the active form, which is the 125 dihydroxylase D3 calcitriol. Right, so both of them are converted to this. Both of them are converted to this, and then this is converted to this. If the patient, if we want to check the vitamin D levels of the patient, we usually measure the 25 hydroxylase B3. That's what we measure. We don't measure the 125. We don't measure that. We measure the 25 hydroxylase D3 one because in lab values it is important as is it is the storage form. So that's how we come to know that whether the patient requires vitamin D or not. Function, it increases the intestinal absorption of calcium and phosphate, bone mineralization, bone resorption at high levels, and regulation is through increased PTH, decreased calcium, decreased phosphate. It basically in turn forms more D3, which leads to negative feedback, and more D3 can lead to increased phosphate and calcium absorption. So decrease in both of these levels can cause increased formation of vitamin D3 active form. Increased PTH can then increase calcium reabsorption and decrease PT phosphate. So this is all easy. You must have known this. What you need to focus on is the regulation that is explained over here. Mostly people know about vitamin D because they have been studying it extensively throughout their medical school. Deficiency can lead to the kids and children, which leads to deformity as bow legs in children, and it can lead to osteomalacia in adults, characterized by bone pain and muscle weakness, hypoglycemic tetany. It can be caused due to malabsorption, decreased sun exposure, poor diet, chronic kidney disease, advanced liver disease. You have to give oral vitamin D to breastfed infants because breast milk is deficient in vitamin D. Darker skin with prematurity predisposed to the deficiency. So this is very important. If the baby is premature, the baby requires iron and vitamin D foremost. Okay. Excess can lead to hypercalcemia, hypercalciuria, loss of appetite, stupor, etc. Mostly serum granulomatous diseases due to activation of vitamin D by macrophages. So this would be your sarcoidosis, you should remember. Okay. And this is the most toxic. So the most toxic vitamin. Okay. And then vitamin E, which is a tocopherol. It is also an antioxidant, and it protects RBC from the neuron and neuronal membranes from free radical damage. So basically, a membrane protector. It can lead to hemolytic anemia if it is deficient, acanthosis, muscle weakness, demyelination of posterior columns, which leads to increased proprioception and vibration. So this is what I want you to remember. This is the most important point. Okay, the neurological problem. It can closely mimic citric ataxia. So make sure to differentiate both of them. And it can also appear similar to vitamin B12, but without megaloblastic anemia. So you need to also make sure to differentiate both of them. So that's why this part is very important. This one is very important. Understanding that it can cause neurological symptoms is very important. Excess can lead to enterocolitis in infants, uh, and it can be caused due to high dose supplementation. And high dose supplementation can also alter the metabolism of vitamin K, right? Because it can lead to anticoagulant effects of warfarin. Basically, it can so increase uh, vitamin E can lead to decrease vitamin K. So what you have to keep in mind. And the second one, we have vitamin K automatically. So vitamin K now includes phytomenadione, phylloquinone, phytonadione, mellaquinone. So you don't need to remember these names. Not important. Function activated by epoxide reductase to the reduced form. The reduced form is a cofactor for gamma carboxylation of glutamic acid residues on various proteins required for blood clotting. So essentially, the reduced form is the cofactor in the gamma carboxylation part. Deficiency, first let's read this section. So necessary for the maturation of clotting factors 2, 7, 9, and 10, and protein CNS, important. Remember them. Warfarin inhibits vitamin K dependent synthesis of these factors. So basically, vitamin K is a uh, procoagulant and warfarin is anticoagulant. It is also synthesized by intestinal microbiota, and dietary sources include leafy greens. Now, deficiency can cause neonatal hemorrhage with increased PT and APTT. This is important. That's why we give vitamin K injection to neonates, as they have sterile intestines and they are unable to synthesize vitamin K. And vitamin K deficiency can also occur after broad spectrum antibiotic use or hepatocellular disease. So both of these are also very important for you to remember. Vitamin K is not in breast milk. D is also not in breast milk, as we've already discussed. So vitamins, neonates are given vitamin K injection at the birth to prevent hemorrhagic disease of the newborn. Correct? I hope that is clear. Zinc is an essential mineral. It's very important. Mostly, it is important in the zinc fingers. Basically, in DNA transcription, it is sort of an enzyme that uses zinc as a cofactor. The deficiency is important. It can cause delayed wound healing, suppressed immunity, male hypogonadism, decreased adult hair, dyschezia, anosmia, associated with acrodermatitis enteropathica, which is basically a congenital defect in intestinal zinc absorption, manifesting with the triad of hair loss, diarrhea, and inflammatory skin rash. So hair loss, diarrhea, inflammatory skin rash around the body openings. So the oral cavity, the anal cavity, and the tips of fingers and the toes. It can also predispose to alcoholic cirrhosis. So all of these are quite important, very important to remember, especially acrodermatitis enteropathica. It's very important. Now, discussing specifically the vitamins are done, the mineral, I think only zinc is important. So now discussing specifically the protein energy malnutrition. Kwashiorkor is a protein malnutrition disorder as well as marasmus. But marasmus is as an overall deficiency in calories. It's not just in protein, right? It, marasmus does not lead to edema. It can lead to muscle wasting, and linear growth is maintained in acute protein energy malnutrition. So, if the patient is acutely malnourished, the linear growth is maintained. Whereas the chronic malnutrition affects the linear growth. So, height is affected by chronic malnutrition. So, CM. Kwashiorkor, on the other hand, is protein malnutrition only. It can lead to edema, skin lesions, and edema due to decreased plasma and cortic pressure due to the decreased formation of plasma proteins that need dietary protein. And serum albumin level will decrease, ADH will increase, liver will be malfunctioning, fatty change will occur due to the decreased apolipoprotein synthesis in the liver. And this child with the swollen belly is a Kawashikor child. This one is the marasmus child. Kawashikor results from protein deficient meals, and this is the symptom mnemonic. So it can cause anemia, fatty liver, skin lesions, hyperkeratosis, dyspigmentation. So you both must understand the difference between both of them, although it's quite basic. And now moving on to ethanol metabolism. Now this is a big cycle, right? You're not supposed to memorize all of it. Ethanol metabolism, the main thing that you must know is the NADH NAD ratio. When there is increased NADH NAD ratio, which means that chronically when you basically intake alcohol, so formation of alcohol or intake of alcohol, metabolism of alcohol increases, increases the NADH NAD ratio. When you take more alcohol, it increases the NADH NAD ratio. So what does this lead to? This can lead to lactic acidosis. This can lead to fasting hypoglycemia. This can lead to lactic acidosis because it increases pyruvate conversion to lactate, right? Why it can lead to fasting hypoglycemia? It because it decreases gluconeogenesis to the increased conversion of oxaloacetate to mannate. It can lead to ketoacidosis because again it can divert the attention of acetyl CoA into ketogenesis, and it can lead to hepatosteatosis because it can increase the conversion of DHAP to glycerol 3-phosphate. Now, of course, if you do not know the basics of these reactions, then this is clearly the part of memorization for you. But if you want to know why this happens, so if you want to understand that why all of these happen, we have to look at it point by point, right? So let's say, for example, that this is a process. This is glycolysis, okay, and this is gluconeogenesis, right? So what happens is that in order for pyruvate, or just focus on what I'm trying to tell you, in order for pyruvate to get converted into lactate, what you need to do is we need to have NADH, right? You need to have more NADH. So pyruvate is going to get converted into uh, lactate, right? However, pyruvate should normally, what should happen is that pyruvate should normally get converted into acetyl CoA. This is the normal pathway because because after being formed in glycolysis, pyruvate goes to acetyl CoA, and then acetyl CoA goes to the uh, it goes to the TCA cycle. But if you have increased NADH, what happens is that because the NADH is increased, and I think you require, it's not written over here. Let me Let me search it. So I could open a cycle glycolysis to TCA cycle. So that it is written clearly. It's not clearly written, but you can see that this is written over here. I want it to be more clear. So let's find us a diagram. Right. So I think this is a clear one. Let me look for another one. All right. So I guess this one is clear. So what happens is that pyruvate normally goes to acetyl CoA, but it needs PDH, right? The pyruvate dehydrogenase complex. And if I can show you also this stuff, this complex. So this is the pyruvate dehydrogenase complex. Okay. So what I was trying to basically tell you guys is that normally what happens is that pyruvate should get converted to acetyl CoA, right, through PDH, pyruvate dehydrogenase complex. And pyruvate dehydrogenase complex requires NAD plus to be converted into NADH. However, if a person consumes ethanol more and excessively, NADH is going to increase and NAD is going to decrease. So this complex is not going to work. So instead of forming acetyl CoA, it is going to go towards the lactate pathway. And it is going to again form a lot of lactate, giving rise to lactic acidosis. That's how it forms lactic acidosis. Right. The main basic, the basis of all of the pathology surrounding ethanol poisoning is this disturbance in the NADH NAD ratio. That's the basic problem, and this can lead to all of these effects. So we've discussed the first one. Let's discuss the second one: fasting hypoglycemia. So now gluconeogenesis needs oxaloacetate, right? So needs oxaloacetate to perform, right? What happens is that oxaloacetate gets converted into malate, and then it can uh, go forward, right? So that what happens is that in due to well, normally what happens is that oxaloacetate uh, needs to get converted into PEP, and PEP then goes down and gets converted to pyruvate, and then pyruvate enters the DCA cycle, right? But again, because of this increased ratio, what happens is that instead of being converted to PEP, it converts into malate, right? Because this reaction requires NADH, and the body is already sufficiently filled up with NADH, so it prefers to use NADH and it gets converted into malate. Again, it leads to fasting hypoglycemia because through this pathway, if oxaloacetate was allowed to go into its normal pathway, it can lead to basically glucose formation. It can lead to ATP formation, right? It can lead to uh, avoidance of hypoglycemia, but again, that does not happen. Ketoacidosis, diversion of acetyl CoA to ketogenesis rather than the ECA cycle. Now, what happens is that even if you say, okay, then what's the bad thing if it gets formed into malate? Well, the bad thing is that TCA cycle is not going to take place. Right? The cycle starts from this, right? And the cycle does not start from this place. And even if we do somehow manage to form acetyl CoA, what happens is that due to increase NADH and decrease NAD plus, it goes and forms keto acids, right? Instead of going forward, because again, it requires the fact to get the it requires NAD plus to go from this process, right? To go towards this process. It does not have NAD plus, so it goes and forms keto acids. And then lastly, it can lead to hepatosteatosis because it can basically increase the conversion of DHAP over here to glycerol 3 phosphate, which in turn leads to increased formation of triglycerides. And this can also, the acetyl CoA can also be converted to fatty acids. So it's a very big cycle. But I just believe that you should just memorize the things that happen, lactic acidosis, fasting hypoglycemia, ketoacidosis, hepatosteatosis, because nobody is going to go into this detail, right? Just memorize all of this, and you're golden, right? Nutrition is mostly tested clinically, so these clinical points you should know. You're not supposed to know every mechanism of everything. There are some important points written over here as well, that females are more susceptible than males to the effects of alcohol due to decreased activity of gastric alcohol dehydrogenase and decreased body size, decreased percentage of water in the body weight, and NAD plus is the limiting reagent. So this is what you should know. This is important. Alcohol dehydrogenase operates via zero order kinetics. You can keep these things in mind, but again, these are not really that important, right? And somiprazole. Now, these are important things. So, fumiprazole is a comparative inhibitor of alcohol dehydrogenase. This is what is used to treat overdoses of methanol or ethylene glycol. Not ethanol, methanol, right? You know the difference between two of them. Alcohol dehydrogenase has a higher affinity for ethanol than methanol. So, ethanol can be used along with fumiprazole. It can be used as a comparative inhibitor of alcohol to treat methanol or ethylene glycol poisoning. So, methanol or ethylene glycol poisoning can be treated by fomepizole and can also be treated by increased administration of ethanol to the patient. Then we have a medication known as disulfiram, which can block acetaldehyde dehydrogenase. And basically, what happens is that blocking this enzyme results in increased acetaldehyde, which leads to increased symptoms. And this discourages drinking. So the patient is going to feel awful and is not going to drink the next time. But this is not really recommended nowadays. It's not really used. And that's it. We finished the nutrition part. That was it. Hope you've understood.